Hi, it's Dr. Lena here again. You're watching this video because you were instructed that you're a candidate for a superior capsular reconstruction. I know it's complex and I know I talked about it in the office, but we'll go through all those issues. Once again, the same risk profile is for this surgery as with all the other surgeries, and the one slight increase would be in failure of fixation associated with the superior capsular reconstruction. The people that are candidate for a superior capsular reconstruction is when the rotator cuff is torn. So when the rotator cuff tears here, it retracts all the way to the level of the glenoid and beyond. If that happens, then sometimes the muscle here atrophies. When there's too much atrophy of the muscle and scarring down of the rotator cuff, we can't mobilize the rotator cuff to put it down into position. So if that is gone, then the shoulder starts to ride high, and if you leave it alone, you will eventually have to get that reverse prosthesis that we talked about in the last video, where it rides up and it gets cuff tear arthropathy. So it's prior to that that we would consider a superior capsular reconstruction. So it's either if you've had a rotator cuff repair that failed, or a rotator cuff tear that has significant atrophy, and you don't have that much arthritis at that time, then you're a candidate for the superior capsular reconstruction. This was developed by a gentleman in Japan, Mihata, in 2008. He did research looking at it. He could not get the reverse prosthesis implant, so he started taking bands of tissue from the leg, and he would ball them up, roll it in, attach the glenoid to the humerus to act as a reverse trampoline to hold that head down, to enable the deltoid to pull the shoulder up and act as the rotator cuff. Subsequently, there's been a lot of research done on this, especially by Burkhardt down in Texas, but it definitely does hold the head down as a reverse trampoline to allow the ball to clear better and hopefully put off your need to have a reverse prosthesis. Essentially, this procedure that I do is arthroscopic only. It is a piece of skin tissue that's very thick. It's 5 millimeters thick. We basically arthroscopically put sutures into the glenoid side, 3 sutures in the glenoid side. Bring those sutures out the side. We do 2 sutures in the humeral side. They come out the side as well. We feed it through the graft after we measure to see exactly where the anchors are so it can be perfectly fit into position. We then feed those sutures through at the appropriate level, and then we basically parachute the skin graft in, reattach it on the glenoid side and on the humeral side with the arm in abduction and forward flexion so that it will increase the tension. And at the end of every surgical procedure, I bring the arm down to the side and make sure I can't force it up into the acromion. And so this is a very viable option for those who do not have severe arthritis, yet have a massive retracted cuff tear with significant atrophy that is not repairable. Thank you very much, and we'll see you in the OR soon.